of that. Okay, so we're going to get started right now. Tracy, we'll start with you, and then maybe after that, we'll take a question or two, and then we'll move to Dawn. And then after that, we're just going to have a dialogue. As they said, you can put your hand up in the chat, or I'll be moderating the chat as well. So with that, Tracy, if you could take yourself off mute and go ahead and chat.
Hello, good afternoon. Thanks for having me. So the way that we approach needing to increase lung screening, we actually had a market-wide nurse navigator program planned. And so it just so happened to roll out in the kind of the March timeframe. So we had 2 lung nurse navigators, one for the north side and one for the south side of Richmond. And, you know, they would go out and visit physicians and talk about screening, what the guidelines were. We have a pre-printed order, which makes it easier for the physicians. We had a nurse that actually coordinated the low-dose CT program, and physicians would contact her and she'd contact them, and she also visited physicians' offices. We have another position in our organization called physician liaisons, who will take our staff out to introduce them to physicians and talk about the lung screening. We also sent out, we had our medical director for medical oncology and then our medical director for surgical oncology. They both drafted letters that had screening guidelines for the low-dose CT screening, and those letters were signed and sent out from our cancer committee, but sent out to all the primary care physicians and the specialists.
Fantastic. Anything else you'd like to share? Those are all amazing things.
Oh, I do think that I would like to share. So initially when we pulled these numbers, we noticed that there was really an increase during the pandemic. And so there's a lot of speculation. So we did, I don't know if because it was a respiratory sort of pandemic, a lot of those patients came in to see their physicians and then were sent for the low-dose CT screening because they didn't really fit criteria for a COVID screening for a diagnostic CT scan. You know, we have outpatient centers, so I don't know if patients were more comfortable going to the outpatient center for their low-dose CT instead of coming to the hospital, maybe for a diagnostic CT. Maybe geographic location. Maybe we had a large population of people that are just screeners and continued to come in anyway. So we could speculate all day, but those were just some thoughts that we kind of batted around.
That's amazing, right? We've seen that anecdotally in some other systems as well. Definitely something that we need to look and see if that's any sort of benefit. Let's take a question or two, and then we'll move to Dawn because I keep looking at the clock. But Catherine asked, how often do you send the physician letters out?
We've only done it once so far.
Okay, and follow up to that is, what was the response?
They didn't know that those were the guidelines. So I think that they didn't say they appreciated it, you know, how physicians can be, but I think that they appreciated the education, and they asked questions and reached out to our nurses and nurse navigators that coordinate the program. So there was a positive response, engagement, and action.
Thank you for that. One technical question for anybody on the call that is helping with the Zoom. Holly Avery is asking that she is in the lung room, but she's listening to breast. So I don't know if one of my colleagues from ECS and or from the COC can help her with that. We do want to make sure that everybody is in the right room. So she's asking how she changes the room audio. And then let's ask Tracy one more question, and then we'll move to Dawn, and then we'll go back and just have a centered conversation with you all. So the other question that we have right here is from Kim, and she wanted to know, when the navigators visited providers, Can you talk a little bit more about that? Was it primarily education regarding the guidelines, or was it more about the mechanics of how to make the referral? It's a really good question, Kim.
It is a good question. And actually, to be honest with you, we were going out to visit to talk about the Nurse Navigator program and how it would work, and letting them know that we were there and that there were specialty sites. But also, we did provide that education and talk to them about how to get it done. All of it.
That's fantastic. Thank you so much for all of this, Tracy. I know we have lots of more questions. The chat keeps lighting up, so feel free to start putting some responses in the chat if you'd like. Okay. I know you also want to listen to all the wonderful things that Dr. Hayes is going to share. So Dr. Hayes, if you wouldn't mind coming up and sharing a little bit about your lessons learned with your interventions on this project from Northside Cancer Institute.
Yes, thank you. I'm excited to be here. So, our lung cancer screening program was started back in 2015, and we had a slow start to our program, and I would say in 2019 we really started to have an increase. And one strategy that we did early on in 2019 and 2020 is we have a lung cancer disease specific care certification with the Joint Commission. And so we actually made one of our quality measures around lung cancer screening. And that really helped to push education to the providers. It helped to set up visits with the providers. We monitored referral patterns from our providers, saw a lot of good engagement with our pulmonologists, but we were missing engagement with the PCPs. And so it gave us an area of focus. So I think that gave us a good jump start. And when this study came out and we were notified about it, it was very fascinating. I went ahead and plotted on a graph our volumes, and we actually matched the graph exactly what we were seeing coming from the group. And we saw that big dip in April. A lot of our centers had shut down, which I think explained a lot of that. But we were very, very fortunate. We had a huge rebound. And I think it was because of the many facets that we had in place. We put a team together that is multidisciplinary. It crosses between our oncology analytics, which is our registry, who took on the job of monitoring our screenings and getting ACR, national database submissions done, and looking at accreditations. We have our clinical team, we have our radiology. And so all that group started, and we've expanded that group. And we're very fortunate with the staff we have. We have a dedicated lung cancer screening navigation team. And this year, one of the strategies that I think has improved our luck with this and improving screenings is we've increased that team from 2 to 4. And our navigators are now looking at real-time tracking of our lung cancer screening, and they do the patient reminders. But I think a unique aspect of what we do, from what I'm hearing from our clinical coordinator, is we do reminders to our physicians at the same time. So at 30 and 60 and 90 day, we're providing reminders not only to the patient, but also to the providers, and we're specifying to the providers what they need to order and what they need to do for the screening, and especially with those follow-up screenings, the annual screenings. And so I think that's been beneficial, and our physicians have received that well. I think Meg's comment about looking at strategies horizontally was very poignant today, because we've been fortunate to focus on patients from a standpoint of reminders and patient education. We have a cancer support community here in Atlanta, and they help to sponsor a lot of our education, and they've been 100% virtual. So I do think we've had a much better outreach in the past year, and it's a positive maybe from the COVID. And then we have, for the providers, done the reminders. We've increased provider visibility with those providers who want to go out and talk about screening. They've been good to do that for us and meet the needs in the community. We have a concierge program set up with radiology, so it's very easy for a physician to call one number and get what they need to do the scheduling. And for the community standpoint, I think our navigators have done a good job in reducing the barriers. Now that they're real time and we've taken care of the backlog, they're able to actually pick up on a nodule of concern very quickly and go ahead and get that patient into a clinic because of the connections. And that has been really beneficial in tapping into some of that care coordination that we haven't been able to do before. And we've actually had a lot of cancers picked up here in the recent months. And so that's been a real plus of the program. But I think, my role really is across the board from a quality standpoint and accreditation. And I think our successes with combining strategies across either a certification, our medical oncology groups have embraced some quality metrics related to their contracts, which has held them accountable to screenings and looking at screening as a plus and looking at the guidelines. And then we have staff in place, leadership that are communicating effectively with the practices on new guidelines, processes. Our EMR is Cerner, and we just implemented a new order system in Cerner to make it easy for the physicians to order the lung cancer screening, whether the patient's inpatient or outpatient. And the education was extended by our radiology group to help make that happen. And so I think our team effort and collaboration really has shown many benefits to our multifaceted program. So.
Wow, there's so much there. Thank you so much for that, Vaughn. So I want to go to the chat first, and then I have a few questions I'd like to ask you. And then I'd love to have Dawn and Tracy just both stay off mute so we can maximize our remaining 5 minutes together. But the question we did have in the chat, and Catherine, this is a really good one. So we all know the lung cancer screening guidelines have increased. The age is now 50 to 55, but Medicare has not yet adjusted this to the age group, and neither has private insurance as well. So she wants to know how navigators have gotten financial coverage for the low-dose lung cancer screening from your institution. So Dawn, would you like to shed a little light about that, or Tracy?
That's a good question. And what we have, we do have a self-pay rate that we've kept low to help patients. And then we do have some foundations in place that can help with financial assistance, and our navigators know how to tap into that. And I think that's probably two methods that we've utilized with some of those patients that fall into those categories.
Fantastic. Go ahead.
Ours are similar. We are a nonprofit Catholic organization. And so we do have a large foundation that assists patients with financial needs.
Fantastic. And just real quickly on that, and then I want to get back to one more question for you, Dawn. So with Medicare, and I'll make sure I drop this in the chat or this is included, but right now the NCD for Medicare is being currently evaluated. I think the decision could likely be February of 2021, or I'm sorry, February of 2022. ACS did support that. There is an expectation that CMS will continue that trend of lowering the age and lighter smoking histories. But I'll make sure you all have that. And yes, thank you, Casey. There are several private insurers that have started taking on and beginning the new guidelines. All of them are mandated to do that by 2023. So Dawn, another question that came in from the chat individually to me was just around how you went around building your multidisciplinary team. How did you do that? And who did you include? Because I don't think we can stress enough the importance of a multidisciplinary team for a quality lung cancer screening program.
So we've built off of our structure. Our cancer committee is system-wide, and then we have what we call multidisciplinary cancer teams, and we have one for lung. And out of that lung team, it's grown in the last 3 years, and we have multiple work groups that spin off of that team, subgroups. And one of them was, it started off as a lung cancer registry team, and then it has now morphed into a lung cancer program team. And it started, and it's been very much supported by one of our pulmonologists who is he's our medical director for lung cancer screening. He's also chairing our steering committee for our team, our larger team, and then he's directly involved in this. And so I really credit him for the push that he's done. He's made plenty of talks at the cancer committee. He's been out in the community. He's been to physician practices, and he has really driven that team. And then I'm a manager of quality and accreditation. We've got a manager of oncology analytics. We have a clinical coordinator for the lung cancer program. We have a lung program coordinator who focuses more on the community side of the program and goes out and does a lot of legwork with our physicians and relationships. And then we've got, of course, our navigators that are dedicated to screening that are separate from our other navigation team. Radiology, we've had the director involved, we've had the managers involved, and then we've got key clinical representatives from each site involved in the meeting. And so that meeting, that small group of team really tackles the operations of the program, and we review the data and we review the referral patterns. And so any glitches, we've got software now that we're utilizing for tracking. We're trying to get software up and running for follow-up and incidental nodule findings. That hopefully will happen by the end of the year. And so again, that meeting occurs every other month now. It used to be monthly, and it really tackles any operation issues. And we've got a physician engaged in that meeting that's asking the questions and pushing some of the issues that he sees his colleagues have. So matter of fact, there was a question today about the Cerner and the ordering system not working, and because of him and the contact, we were able to get that topic on the table and address it right away with the people that needed to take care of it, and it's already been resolved. So I think having that quick turnaround on resolutions has been a big benefit. Kelly, I think you're muted.
Yeah, I promised us not to do that, and then what did I do? My dogs were barking. I didn't want you on for that. We have less than a minute left, so I just want to ask Tracy real quickly, because we're on the topic of multidisciplinary. In 20 seconds, can you just talk a little bit about your team and how you went about building it? And then we'll be going back to the regular room. That went by quick.
Sure. We have a team of nurse navigators, and they kind of pair up. So we have north and south. So we'll have two lung, one north, one south, two breasts, one north, one south, two GI, one north, one south. And then we have a general that's managing some of our GYN onc patients. And then our RN that does the coordination of the low-dose CT. And I see the
Yes.
leave the room sign.
Okay, well, I want to thank you all so much for joining. We all need to go into, because our breakout room will close in 35 seconds. Dawn and Tracy, you both were spectacular. I hope this was helpful for you all. Thank you all for allowing me to be a part of it, and I'll see you all in a few moments.
Thank you.